Hi, I'm Amy Reyes. Before I introduce this week's featured guest, I'll recap some of the headlines from Rheumatology Network this week. We launched a special focus on the diagnosis of axial spondyloarthritis. It included a summary of a study published in the New England Journal of Medicine that examined whether surgery is the better way to manage sciatica from lumbar disc herniation. And we featured an article from physicians writing in Mayo Clinic Proceedings who address factors that should be considered for an axial spondyloarthritis diagnosis. And this week, we published a new column from Dr. Kim Gorgans. She is a Rheumatology Network board member and author of our Awkward Conversations column. This week, Dr. Gorgans addresses long-term quarantine sanity and how to get through the long days ahead of us. And we also published articles on rheumatoid arthritis. One focuses on a study that proposes dividing RA into two different conditions, one with autoantibodies and one without. And in the second story on RA, we featured a study that shows prime cells may serve as a predictor of rheumatoid arthritis flares. And now, today's featured guest is Dr. Vaneet Sandhu, a rheumatologist with Loma Linda University Medical Center in California. Dr. Sandhu is a member of the American College of Rheumatology Communications and Marketing Committee and is the author of a paper published online last fall in Clinical Rheumatology. The article explains health disparities in rheumatology on a global level and here in the U.S. The rheumatologist workforce shortage needs to be addressed on all fronts, she says. Outside of rheumatology, it's not uncommon to find physicians who know little about rheumatic disease. Promoting rheumatology, she says, could resolve some of these problems. In this interview, she explains.
Okay. Hi, my name is Vaneet Sandhu. I'm an associate professor and associate program director of the Rheumatology Fellowship Program at Loma Linda University Health. And I work at both a university-based hospital as well as a community-based hospital, both in education, research, and I'm a rheumatologist at both sites.
Well, welcome to Rheumatology Network. I appreciate your time today. We wanted to talk with you about a paper you published a few months ago on healthcare disparities in rheumatology, the role of education at a global level. The paper is based on a review of published articles on PubMed, and you found some interesting, I think, the findings are interesting in terms of healthcare disparities worldwide and even here in the U.S. Would you mind summing up the results of your study and what your goals were when you set out to do this?
Sure, yeah. So the paper that we wrote was looking at disparities globally and really how we can tackle disparities or at least approach disparities from a rheumatology education standpoint. Really, we start by the question of what are health and healthcare disparities, and a lot of times when we think of a disparity, it's a difference or variation or maybe even inequality. But looking at health disparities, these are disparities that are within a subset, a population. So it could be it's something that's not changeable. It's a race, it's an ethnicity, it's going to be the patient's gender. So it's essentially the identification of a population and how disease disparately impacts that subset of a population. When you look at healthcare disparities, these are disparities within the healthcare system. It may include an institutional disparity. It may be something that's access to care. It may be, even when you go back to the patient, even at a healthcare level, it's access to healthcare. So there are going to be some overlaps between health and healthcare disparities. And what we wanted to do was look at these disparities globally, compare them also to the United States, and what we can do about that.
Mm-hmm. So that was the objective. Sorry, that was the objective of your study, was to address or to analyze health and healthcare disparities globally, and then compare that here in the U.S. Okay, and what did you find?
So we recognize that that the health system is a key proponent to health access for all, but there are many social determinants that impact world health. So examples, like I mentioned earlier, were access to healthcare. And that was really one of the big things that we focused on, because there's a massive workforce shortage in the United States alone. We're expecting such a substantial increase in healthcare providers by 2030. Despite this, the distribution of rheumatologists specifically in different parts of the United States is actually quite disparate. So you're going to have actually an increase in rheumatologists, but they're going to be predominantly in the urban areas, whereas the booming population in the United States is actually in rural areas where the number of rheumatologists is decreasing. So you're having an increasing recognition of rheumatic diseases, a decrease in the appropriate distribution of rheumatologists, and overall a generalized shortage of rheumatologists, because we still need more. And that's going to largely impact our population.
When we were talking earlier, you went over statistics globally. You said there were 1 in 1,000 people, I think, in India who have access to a rheumatologist. Is that correct?
Right. So we're looking at when we look at it at a global level, the degree of disparities are profound compared to the US. So I'm talking about the shortages that we have in the US, but let's just say if you look at the number of doctors and nurses per 1,000 people in the US is roughly 12. In India, it's 1.6. So you see I mean, that's just one example. In China, where there are millions and millions of dollars that are going towards research funding, whether it's coming from the government or the private sector, there's still a workforce shortage. So that shortage is profound globally. And some ways that countries, including the US as well, but other countries have actually worked on addressing this. An example would be in Singapore. They have a rheumatology monitoring clinic, which is run by an advanced practice nurse and a pharmacist. So they essentially run a rheumatology clinic, and that's their one approach to how to address this workforce shortage. Similarly, there's a program that's called the Training for Health Equity Network. And this is a global program that what they're doing is, it's established by 7 schools of medicine, which is, I believe it has expanded now, but it's a community-based service learning approach, which is, it's more of a tackling this workforce shortage at a medical education level. So you're actually teaming up with medical institutions and having them do their teaching at the community-based level. And this ultimately encourages the long-term retention of healthcare providers within that area. Now, that model is not a rheumatology model, but that's me jumping ahead and kind of looking at this as a potential solution for our workforce shortage and our improving health access for all. Right. Picture. So this is the unfortunate part about giving percentages for gaps in other countries. Because not enough research is being done in other countries, we don't have the information for how big the gap is. To paint a picture of workforce shortage, so for example, Micronesia and Guam, they shared a single rheumatologist up until 2018. They had 1 rheumatologist to cover both regions. In Australia, only 15% of the indigenous peoples possess private insurance. Public funding will only cover your primary care and your oral care. So the access to care is the big issue. The percentage of providers that are rheumatologists that are available in these regions, that data is not clear. So when we were working on this paper, even reaching out to get this information was difficult because not everybody knows. In India, the data that I found was there were about 100 rheumatologists, and 20% of them had been trained outside of India. In Pakistan, the number of rheumatologists, 50% of them were trained outside of Pakistan. So that's highlighting an issue of really trying to encourage retention within your country as far as your education goes, and then also to promote retention to stay within your country too. So these are the emphasis on providing stats and percentages as far as the gaps within different regions. The biggest issue there is that we haven't had enough research to understand these regions. And that's probably the biggest disparity of all. Is in the United States, we know, or we can say that lupus it disparately involves women of childbearing age. The minority groups are more largely affected by lupus. There are more poorer outcomes. But how does that translate to other countries?
Right.
And even within our own populations, we need more information, because do we have the best sample size? Is our research truly being representative of the population that we're commenting on? So this is kind of this tiered approach to how do we tackle disparities. It's not just one thing. We know that there's a workforce shortage. We need more rheumatologists. How do you get more rheumatologists? You open up more spaces within medical schools. The curriculum for rheumatology training needs to be adjusted so that you're either so that you incorporate health disparities and healthcare disparities within rheumatology education. Advocacy needs to be promoted. In order for our field to grow, we need advocacy. Most of my colleagues don't really know a whole lot of rheumatology, and so a lot of people just kind of think we only see people who have osteoarthritis, and the majority of our patients are in their 70s or 80s, and that's it. And I think it's so this is not just a reaching out to the public, it's also within our own community, where we have within our own healthcare providers that we need to increase education on rheumatology. And once we start to promote more of what rheumatology is and what it's all about, that's also going to help with our workforce shortage. People just need to know what rheumatology is. And we need more, and we need more people that are doing research in health and healthcare disparities. I've been fortunate to work with some of my colleagues on the other side. I'm in California, so some of my colleagues on the East Coast, the Midwest, who are doing a lot of work in health and healthcare disparities. One of the biggest reasons why I am where I am is I'm serving an underserved population. And I think that research in underserved populations can be challenging. There are a lot of factors behind doing research within an underserved population. There are a lot of factors that come into play. They may be cultural. They may be related to trust or distrust of the institution or of the healthcare industry. So there are a lot of factors that come into play that we really need to consider when we're doing this just within the United States alone, which is a cultural pot.
Mm-hmm. Mm-hmm. Well, certainly. Now, how dire is the need here in the U.S. as compared to other disciplines? For example, there are many more oncologists per cancer cases here in the U.S., are there not?
Yeah, yes, valid point. Yes, it's dire. I think what's often missed is that the call for, and not to underplay cancer, because it's cancer, but I think that what is largely missed is that musculoskeletal diseases are the leading cause for morbidity. And so, yes, a lot of our diseases are the increased mortality, but people don't realize that how much this quality of life impact that musculoskeletal diseases and our autoimmune rheumatic diseases in general have. You're impacting the quality of life, and that's ultimately impacting our healthcare system. It's an economic burden, so it is largely under-recognized. And I'm not even including the component of osteoporosis, fractures, and that part of rheumatology that's also very frequently missed.
The National Institutes of Health would have interest in this because the cost of morbidities alone must be very, very high as compared to just treatment of the condition. If you were more proactive to control morbidities from worsening, wouldn't that at least impact the bottom line in terms of where the federal government diverts its research funds or anything of that kind? And wouldn't it be more helpful to address these things that really, really do impact our healthcare economy?
On the same page as you. So this is where I can't emphasize enough the importance of advocacy. So yes, the NIH has interest, but there are more diseases and disciplines that have had a larger voice. And so I think our voices need to be louder and heard. And I do see that coming. I see it happening. I am an active member of the American College of Rheumatology Communications and Marketing Committee. My colleagues are part of the advocacy committee. So it will come, and it is coming. So the amount of the increase in awareness within the NIH or NIAMS for health and healthcare disparities, it's there. They are providing grant funding, but we just need more is basically what we need. Mm-hmm. And a lot of it needs to be, I think that we need more attention towards these underserved areas within the United States.
Mm-hmm. And without any support, additional support, what does the future hold for rheumatology in terms of these disparities that we discussed today?
So without support, you're going to rely on more rheumatologists that are kind of just doing things out of the goodness of their heart, and a continued shortage. Because if we don't have more rheumatologists working in these underserved areas, what's going to happen is, let's just say, for example, where I started working, it's a county hospital. When we first started working there, when I first joined 5 years ago, we worked the inpatient setting only 1 day a week. 1 day a week of covering the hospital consultations for rheumatology. And the number of cases that I was seeing in the span of my first 6 months there, patients who, for example, had vasculitis and had progressed to needing dialysis. This was because they did not have access to us. They were being treated by providers that did not have the experience in rheumatology. And so that's what's going to happen, is if we are not providing our services in these underserved regions, then those patients will be left at the hands of well-intended providers that don't have the experience in rheumatology that they need in order to be providing those services. So until we increase the number of rheumatologists or increase our rheumatology champion programs for healthcare providers, we are going to have a pretty bad problem.
Mm-hmm. Okay. Is there anything else you'd like to leave us with us today?
Advocate, advocate, advocate. And medical education. I think one of the big things is social accountability, and the concept of medical education programs really being the key for encouraging, educating, inducing advocacy in your learners. I think it's just so important. If a learner does not know that they need to advocate, if a learner is not pushed to do research, if a learner is not pushed to serve, they are not going to know. And I think it really starts at a medical education standpoint first.
Mm-hmm. Okay. Well, thank you for your time today. We hope to follow up with you in the future. And
thank you so much.